Hello and welcome to the topic Myeloproliferative diseases in the Haematology module. By the end of this topic, you should be able to define myeloproliferative diseases, explain the pathophysiology of myeloproliferative diseases, outline the causes and classification, describe the clinical manifestations of myeloproliferative diseases, outline in the investigations done for myeloproliferative diseases, discuss the principles of management and the complications as well as the prognosis of myeloproliferative diseases. Let's get started. Myeloproliferative diseases are a heterogeneous group of disorders characterized by clonal proliferation of normal multipotent hematopoietic stem cells of the myeloid line. The most common of myeloproliferative disorders are chronic myeloid leukemia, essential thrombocythemia, polycythemia vera, and primary myelofibrosis. Less common myeloproliferative diseases are hypereosinophilic syndromes and mastocytosis. Myeloproliferative diseases can also overlap with myelodysplastic syndromes. Studies have established that the clonal origin of myeloproliferative diseases likely occur at different stem cell levels. However, a common attribute to these myeloproliferative diseases seem to be an acquired activating mutation in the gene coding for tyrosine kinases. In CML, there is increased tyrosine kinase activity of the BCR-ABL fusion gene. In polycythemia vera, essential thrombocythemia and myelofibrosis, the mutation appears to be a valin to phenylalanine substitution at amino acid position 617 with genus kinase 2 or JAK2 gene, which produces hypersensitivity to erythropoietin. Due to this common driver JAK2 mutation, there may be overlap in clinical and laboratory findings, though in each of these disorders, proliferation of one or more cell types dominate their classical picture. For example, in primary myelofibrosis, gene mutations leading to hyperplasia of atypical megakaryocytes followed by an increase in TGF-B, then increase in fibroblast activity which eventually causes bone marrow obliteration due to fibrosis and displacement of hematopoietic stem cells. All of these events end in extramedullary hematopoiesis. Overall, because there is clonal proliferation of a pluripotent hematopoietic stem cell, which results in an increase in red blood cells, white blood cells, platelets, and also progenitors in the bone marrow. Systemic mastocytosis is linked with D816 mutation of the KIT gene, while the FIP1L1 PDGFR mutation has been identified in a subgroup of patients with systemic mastocytosis with eosinophilia. The exact cause of myeloproliferative neoplasms are unknown. However, there is likely to be multi-step that involves more than one gene mutation. In CML, most patients have the Philadelphia chromosome, which is the T9 and 22, which even if they test negative for, they often still test positive for the fusion BCR-ABL gene. This BCR-ABL gene encodes a fusion protein with tyrosine kinase activity, which is constitutively expressed, and this is the central mechanism of the chronic phase of CML. Myeloproliferative diseases are classified based on abnormalities. Listed are the more common disorders. Essential thrombocythemia, where the thrombocytosis with possible bone marrow fibrosis occur. Thrombocythemia here can lead to microvascular occlusions, mainly affecting smaller vessels of the distal extremities and the eye that is usually reversible. Thrombosis is in larger vessels, either deep vein thrombosis or pulmonary embolisms and bleeding. Primary myelofibrosis, in which there is anemia, leukocytosis and marrow fibrosis or scarring with accompanying extramedullary hematopoiesis. Myelofibrosis is a reactive, reversible increase in bone marrow collagen with extramedullary hematopoiesis. Polycythemia is where there is a combination of erythrocytosis with concurrent increased white blood cells and platelets. Sometimes there is extramedullary hematopoiesis. Approximately 10 to 30% of patients eventually develop myelofibrosis and marrow failure, whereas acute leukemia spontaneously occur in 1 to 2.5%. These patients are also at an increase of risk of bleeding and thrombosis. Common clinical manifestations include splenomegaly, macro or microvascular events such as transient ischemic attacks, ocular migraine, and aquagenic pruritus. Then there is chronic myeloid leukemia, where there is granulocytosis and thrombocytosis. Depending on the type of myeloproliferative disorder, symptoms may be reported with varying frequency and intensity. Common symptoms are fatigue, anorexia, and weight loss. abdominal discomfort and or early satiety secondary to splenomegaly, and this is most common in CML, easy bruising and or excessive bleeding, swollen painful joints due to gouty arthritis secondary to hyperuricemia, priapism, tinnitus and stupor as a result of leukostasis, and left upper quadrant and left shoulder pain. Moving on to clinical signs found in myeloproliferative diseases, the most common signs picked up by the clinicians are pallor, plethora, petechia, palpable spleen or liver. Fever and skin lesions, often maculopapular violaceous lesions on the trunk, arms, legs and face, and acute febrile neutrophilic dermatosis or Sweet syndrome. Investigations are prompted by characteristic clinical symptoms and or abnormal findings on physical exam. Initial studies can include a complete blood count that detects changes in myeloid cell line parameters, whereas a peripheral smear can pick up morphological changes. A complete metabolic panel can indicate disease burden due to increased cell turnover by tracking LDH, uric acid, and LAP. Radiological imaging of the abdomen with CT or ultrasound can help identify hepatosplenomegaly. Confirmatory studies that are required to diagnose myeloproliferative disease are genetic testing and bone marrow biopsy. Genetic testing starts off with an initial mutation screening of the Philadelphia chromosome that accounts for the fusion BCR-ABL gene present in virtually all cases of CML. Other driver mutations such as JAK2, CALR, and MPL mutations are also screened for due to their association with polycythemia vera, essential thrombocytosis, and primary myelofibrosis. Then subsequent mutation testing for atypical driver mutations and non-driver mutations such as CSF3R and other high molecular risk mutations. A bone marrow biopsy is often required to confirm a definitive diagnosis, as many myeloproliferative disorders have overlapping lab and clinical findings. Many myeloproliferative diseases are overlapping. Here is an attempt to summarize the distinct features of the most common myeloproliferative disorders. First off, in essential thrombocythemia, clinical and lab studies classically show isolated thrombocythemia, while a peripheral smear reveals large hypogranular platelets. Most patients, approximately 50 to 60% of patients, have a JAK2 mutation, followed by a smaller percentage with CALR and MPL mutations. Bone marrow investigations will reveal an increase in large mature megakaryocytes without any increase in granulocytic or erythroid precursors. Then in polycythemia vera, there is an increase in hemoglobin, hematocrit, and red cell mass, and this is all due to increased RBCs. A decrease in erythropoietin follows, and patients may also present with increased platelets, white blood cells, and LAP. On a peripheral smear, there is normal morphology without any pathological cells. Nearly all patients with polycythemia vera have an underlying JAK2 mutation. Bone marrow examination reveal hypercellularity, panmyelosis, and pleomorphic mature megakaryocytes. Moving on to primary myelofibrosis, classically reveals a palpable splenomegaly with remarkable decrease in hemoglobin, increases in white blood cell and LDH. Peripheral smears typically reveal leukoerythroblastosis and teardrop cells. Again, over half of all patients have a JAK2 mutation with smaller subsets of CALR and MPL mutations. Bone marrow aspirations are often hard to obtain and yields a dry tap due to severe marrow fibrosis. Biopsy may reveal increased atypical megakaryocytes of all stages. Bone marrow biopsy will also find atypical megakaryocytes, and it's likely to be either a pre-fibrotic or fibrotic stage. If it's in the proliferative stages, there is typically hypercellularity with increased granulopoiesis and possible reduced erythropoiesis. In CML, there is splenomegaly, marked increase in white blood cells, increased platelets, decreased red blood cells, and decreased LAP. On peripheral smear, there is elevated basophil count, and there may be pseudo-Pelger-Huet anomaly. The majority in patients with CML have either Philadelphia chromosome or the BCR-ABL fusion gene. Bone marrow examination will show hypercellularity and increased myeloid to erythroid ratio. Regarding management, the treatment of choice depends on the underlying diagnosis, risk factors, and comorbids. In general, a wait and watch approach is used if the disorder is deemed to be low risk. High risk or symptomatic myeloproliferative disorders are managed symptomatically, and an attempt to delay disease progression is made. Supportive care includes thromboembolism prevention with antiplatelet drugs such as aspirin, Therapeutic phlebotomy to reduce blood viscosity by decreasing hematocrit. Symptomatic splenomegaly is managed by elective splenectomy or splenic irradiation. JAK2 inhibitors and cytoreduction with hydroxyurea and interferon alpha. Symptomatic cytopenias such as bleeding from thrombocytopenia and symptomatic anemia can be managed with blood or platelet transfusion. Erythropoietin and analogs such as androgenic steroids, danazol, prednisolone, immunomodulators like thalidomide and its analogs, lenalidomide and pomalidomide. Disease-specific therapy include targeted therapy and allogenic hematopoietic stem cell transplantation, which is potentially curative but only made available to a select few. Interestingly, there is no curative modality currently available for essential thrombocythemia. Treatment is mainly focused on relief of symptoms and keeping platelet range in check, usually achieved with hydroxyurea and anagrelide. Pharmacotherapy aims to reduce morbidity, mortality, and complications. The main classes of drugs used are interferons, antimetabolites, and tyrosine kinase inhibitors. Interferons are proteins with antiviral, anti-tumor, and immunomodulatory potential. These are recommended in the initial management of low-risk CML as many patients on interferons achieve hematological and molecular remission. They also have prolonged survival. Moving on, antimetabolites are also commonly used in the management of myeloproliferative disorders. These drugs inhibit cell growth and proliferation. Hydroxyurea, an anti-neoplastic agent, controls symptoms associated with leukocytosis, thrombocytosis, and hepatosplenomegaly. Anagrelide, on the other hand, acts to reduce elevated platelet count in patients with essential thrombocythemia and polycythemia vera. Ruxolitinib is a JAK1 and JAK2 inhibitor which reduces symptoms, decreases splenomegaly, and corrects blood parameters, and this is used in polycythemia vera and myelofibrosis. In CML, targeted therapy utilizes tyrosine kinase inhibitors, and these agents inhibit BCR-ABL tyrosine kinase to decrease the proliferation and increase apoptosis. The first-line drug is first-generation TKI imatinib. Second generation such as dasatinib and nilotinib can be used as well. In polycythemia vera, first-line management is simple periodic phlebotomy to reduce the number of red cells, hence reducing hyperviscosity. Approximately 250 to 500 ml in intervals of 2 to 3 days is removed until hematocrit is less than 45%. Aspirin is given as prophylaxis against thromboembolic events as platelets are less affected by phlebotomy due to their shorter lifespan and regeneration period. Cytoreductive therapy is recommended if risk factors are present or if first-line management with phlebotomy and aspirin is either ineffective or poorly tolerated. In the management of essential thrombocytosis, risk scores and screening for high-risk features are used to stratify patients into risk groups that determine their management approach. Low to intermediate risk patients are managed mostly with a wait and watch approach with close monitoring. Besides that, low-dose aspirin can be considered. High-risk patients have to be treated to prevent thrombohemorrhagic events. First, start these patients on low-dose aspirin, then reduce the platelet counts with an antimetabolite, either hydroxyurea, anagrelide, or interferon alpha. Lastly, in the management of myelofibrosis, similarly, patients are screened and stratified to risk groups that direct the management approach. Again, in low-risk patients, observe. Treatment should be started in moderate to high-risk patients, symptomatic anemia and symptomatic splenomegaly. Supportive care includes thromboembolism prevention with low-dose aspirin, antimetabolites, splenectomy for symptomatic splenomegaly, and transfusions or thalidomide for symptomatic cytopenias. Disease-specific therapy utilizes JAK2 inhibitors such as imatinib and allogenic hematopoietic stem cell transplantation that is potentially curative. In CML, it is possible that disease progression complicates into its accelerated phase or the terminal blast phase. Following this blast crisis, some patients go on to develop AML or ALL. Polycythemia vera can be a life-threatening disease as there are many complications associated with it. First, there would be venous or arterial thrombosis, most commonly DVT and strokes or myocardial infarctions. Hemorrhagic complications such as petechiae, epistaxis, and bleeding gums are also commonly seen in patients with polycythemia vera. Hyperuricemia due to raised cell turnover can lead to gouty arthritis. In its later stages, there is possibility that it transforms into AML or MDS. Depending on the presence of additional genetic mutations, Myelofibrosis also can occur if there is fibrotic transformation of the bone marrow. In essential thrombocythemia, complications include secondary myelofibrosis, leukemic transformation, thrombosis, and spontaneous abortion. Finally, the complications of myelofibrosis are myeloid metaplasia and leukemic transformation of AML. In CML, the 5-year survival for patients 20 years and older is 67%. Without treatment, the survival rate is much lower. Median survival for patients with primary myelofibrosis is approximately 5.5 years. This estimate is shorter than that of polycythemia vera and essential thrombocythemia. A good prognostic factor in CML is response to tyrosine kinase inhibitors, and this is actually an important prognostic factor in CML. Response is measured at baseline, then at the 3rd month, 6th month, and at a year. Assessment of response to tyrosine kinase inhibitor is done with molecular tests measuring BCR-ABL protein or cytogenic tests measuring the PH chromosome cells. Additionally, on the bright side, life expectancy in essential thrombocythemia is near normal. The cause of disease is practically benign and complications are rare. On the flip side, bad prognostic factors include myelofibrosis, which is likely to transform into AML, anemia, a history of transfusion, leukocytosis, and thrombocytopenia. Recent studies have cited a median survival of 24 years in polycythemia vera, but many go on to live for much longer, even after myelofibrosis develops. Thrombosis is the most common cause of death, followed by complications of myelofibrosis and the development of leukemia. Other bad prognostic factors are being aged above 67, having a splice-some mutation such as SRSF2, and a history of thrombosis. To summarize, myeloproliferative diseases are a heterogeneous group of disorders characterized by cellular proliferation of myeloid cell lineage. The most clinically relevant of the lot are chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, and primary myelofibrosis. Despite the exact etiology being unknown, a common attribute to these set of disorders appears to be an acquired mutation in the gene coding for various tyrosine kinases. An important etiological factor is the JAK2 gene mutation in most cases. CML, on the other hand, is characterized by BCR and ABL fusion gene or the Philadelphia chromosome with translocation 9 and 22. Generally, there are overlaps in the clinical and lab findings in myeloproliferative disease because they all have driver mutations that constitutively activate the JAK2 gene. Lab studies include a full blood count, a lab score, red cell mass studies, serum acid levels, and PCR assays. A bone marrow aspiration and biopsy with cytogenetic studies may also be required in select cases. Treatment also varies according to the disease subtype. Management generally involves symptomatic management, keeping blood parameters in check, halting proliferation of malignant cells, and ASCT with curative intent if possible. We have come to the end of this topic. Thank you.